Hello doctors, today we will see the part 3 of plain and contrast X-ray. If you have not seen the part 1 and 2 of X-ray chapter, I will give the link in my video description so that you can go and watch it. So in this part 3 of X-ray, we will see mainly the chest X-rays and the fundamental of the chest X-rays. So starting with the fundamentals, first we have to know the assessment of exposure of quality of the film penetration, whether the chest X-ray film is properly penetrated or not. On high quality radiograph, the vertebral body should be visible through the heart. Means this is the heart, and from this the vertebral bodies through should be visible. Then only we can tell that whether the exposure quality is enough or not. Like here there is more exposure and here there is less exposure. This is the adequate exposure quality of an X-ray. Now second that we will see in chest X-ray is whether this is an AP view or PA view of chest X-ray. Here we can see two X-rays. This is the AP view and this is the PA view of chest X-ray. In AP view of chest X-ray, the cardiomediastinal contour is significantly magnified. This area is significantly magnified on this AP film, and this needs to be appreciated and not overcalled. And in cases of PA view taken, the mediastinum appears to be normal in size in PA view. So in AP view, we see the cardiomediastinal contour significantly magnified in AP view. In this way, you can differentiate between whether it is an AP view or it is an PA view. Now, third point is patient dependent factor, whether the patient is standing properly while taking X-ray or not. In this case, the assessment of patient's location is very important. Whether the patient rotation is important. Patient rotation may result into normal thoracic anatomy becoming distorted, and cardiomediastinal structures like lung parenchyma, bones, and soft tissues may appear more or less conspicuous. If in cases of normal, if there is no rotation present, then this is the spinous process of the vertebra, and this is the medial end of one clavicle and medial end of the right clavicle. From the spinous process of vertebra, both the clavicles should have an equal distance. Then we can say that the X-ray film is not rotated. Here we can see this is a normal view, but a well-centered X-ray this is. But here we can see that this is a rotated film. If you see, this is the spinous process. The right side is closer. The right medial end of the clavicle is closer than the left side. So this is a rotated film, and this is a normal X-ray which is non-rotated. Now, fourth point that you have to see is the assessment of adequacy of inspiratory effort. If the X-ray is taken after doing in proper inspiration, then we over the anterior aspect we can see minimum of 6 ribs, and in the posterior aspect, like this is the anterior ribs, these are the anterior, and the posterior one, these are the posterior ribs. As you can see here, these are the posterior ribs. We can see 10 posterior ribs and 6 complete anterior ribs if there is proper adequacy of inspiratory effort by the patient. Then we can see 6 complete anterior ribs and 10 posterior ribs are clearly visible if there is adequacy of inspiratory effort. So these are the important things that you have to see. Number 1, I will repeat. Number 1, first you have to see whether you have a proper exposure in the X-ray film. Number 2, you have to see whether it is an AP view or PA view. Number 3, you have to see the patient dependent factors, whether the film is rotated or not. Number 4, you have to see proper inspiratory effort. Adequacy of inspiratory effort is seen. Now, here you have seen there is poor inspiratory effort in this X-rays. Therefore, all the 6 ribs in the anterior aspect and the posterior aspect, we cannot see the 10 ribs in here. Now we will see some important anatomy in the chest X-ray. First, starting with the heart and the mediastinum. So if we see this is the heart, then if we mark this as A, and from one costophrenic angle to the other costophrenic angle, this is marked as B. If we divide A by B, then it should be approximately near 0.5. If it is more than 0.5 in PA view of X-ray, if it is more than 0.5, then we have the cardiomegaly. If the ratio is more than 0.5, then it is cardiomegaly. So this A should be half or less than half of the B. This is the assessment of heart size that you have to see in X-ray. Apart from that, you have to see the areas. So this is the SVC over the right side. This is the area of SVC. This border, right border that we see, this is formed by the right atrium. In the anterior aspect, the large area that we see is the right ventricle. And in the cardiac apex, this is the cardiac apex. And above this line, this cardiac apex denotes the left ventricle. Then we have the left arterial appendages here, pulmonary trunk, then we have the aortic arch. These are some of the cardiomediastinal contour. This is the cardiomediastinal contour. SVC, right atrium, right ventricle, left ventricle apex, left ventricle, left arterial appendages, then pulmonary trunk and the aortic arch. These are the contour of the cardiomediastinal. Then we have to see assess the diaphragm. Careful examination of each diaphragm is very important. And remember, the right hemidiaphragm is higher than the left. This is the right side and this is the left side. This right hemidiaphragm is above. This is higher than the left. How much higher? This is 1 to 1.5 centimeter higher. The right hemidiaphragm is 1 to 1.5 centimeter higher than the left side. And each costophrenic angle should be outlined very sharply. So this is about the hemidiaphragm. You can see the right hemidiaphragm is 1 to 1 centimeter higher than the left one. Another thing that you have to see is the curvature of the diaphragm. We have to see the curvature of, this is the curvature of the diaphragm. So how we will see that? We will draw a line on the highest point of the hemidiaphragm. This is the highest point. We have drawn a line, highest point of the hemidiaphragm. And we will draw a line from the cardiophrenic angle to the costophrenic angle. We will draw another line. So this height should also be more than at least 1.5 centimeter. This height should be at least 1.5 centimeter. We have drawn a line from the highest point of hemidiaphragm and another line from the costophrenic angle to the cardiophrenic angle. This is the assessment of the diaphragm. Now we will see few of the pathologies of the chest X-ray that may be asked in your exam very quickly. So first, this is an X-ray of chest X-ray, and over the left upper lobe we have an air fluid level. So this is an lung abscess. How will you know this? Immediately within 72 hours, if we do an X-ray, then generally it is normal. But after 72 hours, we can see a cavitation, and this cavitation is generally more than 2 centimeter of diameter. But it can also be as big as more than 12 centimeter in diameter. So, and there is a characteristic air fluid level also present. And if we do a CT scan of this patient, then we will see that the abscess wall is thick, irregular, and may contain locules and free gases. And there is generally no compression in the surrounding lung. And abscess generally do not cross the fissure lines. Here also in the lateral view, you can see the abscess of lung, and this is the air fluid level and cavitation. Now we will see the bronchiectasis. Bronchiectasis is what? It is a localized irreversible dilatation of bronchi, often with thickening of the bronchial walls. So this is an X-ray of bronchiectasis. Here we can see a widespread bronchial wall abnormality in the both lung, but particularly over the right side, in the right lower zone, there is marked bronchial wall thickening. So, and these lines which are visible, these are known as tram lines. In bronchiectasis, we see tram lines in X-ray. But if we do CT scan, we can see predominantly in the middle and the lower lobe, there is marked bronchial wall thickening. And there is rings. These rings are known as, these black rings, these are known as signet rings. These are known as signet rings that we see in CT scan in a patient of bronchiectasis. So radiologically, I have already told, most common site for bronchiectasis is the posterobasal segment of the lower lobe. By bronchiectasis is 50% patient, they have bilateral involvement. Chest X-ray, we will see dilated, thick-walled bronchi giving cystic and tram-line appearance. I have already told you tram-line appearance, and honeycomb appearance is also seen, and these are associated with infective consolidation and pleuroparenchymal distortion. In HRCT, we lack the bronchial wall tapering is the most consistent feature, and signet ring sign. In HRCT, we see the signet ring sign. Now we will see the collapsed lung. This is an X-ray of collapsed lung. So in lung collapse or atelectasis can affect the whole lung or a single lobe or a segment component. A lobar collapse, important, do not miss in the imaging. Lobar, if the one lobe is collapsed, it is easily identified. Here, as you can see, right-sided upper lobe is collapsed. So easily collapse is identified in cases of X-ray, and the underlying cause, it may be malignancy. There might be an obstructive causes or non-obstructive causes. Obstructive causes like it may be a tumor or foreign body, mucus plug, stricture, or bronchial rupture may be present. And non-obstructive causes are pleural effusion and pulmonary fibrosis. These are the non-obstructive causes of lung collapse. In lung collapse, remember, we can see the collapsed lung as well as generally if there is a severe collapse, then the mediastinum is pulled towards that side. There is shifting of trachea towards the side of pathology in cases of lung collapse. And in cases of consolidation is also look similar, but in cases of consolidation, the trachea is in normal position. And in cases of lung collapse, the trachea is pulled towards the site of pathology. So this is a lung collapse. Then we will see the flail chest. I have already explained flail chest in very detail in part 2 of thoracic trauma and also in the part 1 of thoracic trauma. You can go and watch that video, or I will give the link of that video in my description. So this is the X-ray of a flail segment. You can see a multiple rift fractures. What is flail segment? When there is more than 3 rift fractures are present in 2 consecutive ribs. In 2 consecutive ribs, there is more than 2 rift fracture. Costochondral separation may be needed, and air spaces shadowing may be seen in pulmonary contusion, and there may be associated pneumothorax or hemothorax with flail segment of chest. There is paradoxical respiration in cases of flail segment. Then we have the hemothorax. In hemothorax, we will see the blunting of CP angle. This is an erect X-ray of chest, and blunting of costophrenic angle is seen over the left side, and generalized increased opacification with time we can see. And the management of this is IV fluid stabilization and ICD insertion. So it may be because of penetrating injury to the chest or blunt trauma chest, or it may be due to aortic rupture or multiple rift fracture. Because of that, hemothorax might occur. Then we can have the metastasis. Metastasis of chest seems like this. It might be a cannonball metastasis or a miliary metastasis. Cannonball metastasis is, in this X-ray, solitary or multiple round-shaped lung lesions are seen. They may be calcified like in osteosarcoma, breast or thyroid cancer. These cancer generally metastasize to the lung, or they may be small like in thyroid, breast, prostate cancer. There might be small metastatic. And hemorrhagic metastasis is seen in choriocarcinoma, melanoma and thyroid. And endobronchial lung, lymphoma and breast, renal and colorectal are carcinoma, endobronchial generally. These are the different type of carcinomas that metastasize to the lung. This is the cannonball metastasis. By seeing the picture, you can easily identify it. And this is the miliary metastasis. These are the metastasis, X-rays of metastasis. Now we will see the pulmonary effusion. Pulmonary effusion, here costophrenic angle obliteration is generally happens when there is fluid more than 300 ml. So initially, when the fluid is less than 300 ml, we can miss that in pulmonary effusion. There may be blunting of costophrenic angle, radio opaque density is seen. Here also we can see here we can see the fluid is going up towards the lateral chest wall. If the fluid is tracking up towards the lateral chest wall, then this is known as meniscus shaped. This is known as meniscus shaped upper surface of the right pleural effusion, and this is seen in the lamellar type of pleural effusion. And here this is an loculated pleural effusion. This is a loculated. This is in one side. We do not see meniscus sign in loculated pleural effusion. So this is loculated pleural effusion. Another one, that is, it can be encysted also. It can be encysted pleural effusion also. Here Effusion may track up to the lateral chest wall in laminar one. This is the laminar one. Here the effusion is tracking up towards the lateral chest wall. This is the lamellar one. It may be irregular in outline, that is loculated, or track along the mediastinal pleural space resembling lower lobe lung collapse. And the track along a fissure, then this is known as encysted pleural effusion. These are the different type of pleural effusion. You will generally given like this type of X-ray. This is the pleural effusion, and management is generally ICD insertion. Now this is a pneumothorax. Pneumothorax is very common in trauma, and I have explained the pneumothorax in part 1 of traumatic injury. You can go into the playlist and go to the trauma section, and then you can watch the video on thoracic injury part 1 for detailed features of pneumothorax. Pneumothorax, here we can see an inspiratory field, and this is an expiratory film. In expiratory film, we can easily visualize the pneumothorax. Here, when there is minimal pneumothorax in the inspiratory field, you cannot visualize pneumothorax so good. You can see here, you cannot visualize pneumothorax better. But in cases of, in that same patient, if we do an film in expiration, here we can see this is the lung lobe, and there is no bronchovascular margin towards this side. So this is the pneumothorax, and we can easily visualize pneumothorax in during expiration when the film is taken. And another thing, that is the tension pneumothorax. This is the tension pneumothorax. You can it is easily visible in both inspiratory and expiratory X-rays. And in this you can see no bronchovascular margin is seen. This is a left-sided large pneumothorax with early mediastinal shift towards the right side. Because of the pressure of the air in the pleural cavity, it pushes the mediastinum trachea towards the opposite side. This is an emergency management, and it is done. We can insert an ICD and in the triangle of safety and manage the cases of tension pneumothorax. This is another X-ray of tension pneumothorax over the left side. This is a barotrauma associated with ventilation results in accumulation of the air within the pleural spaces. This is another X-ray showing pneumothorax. And so simple pneumothorax, the visceral pleural edge is visible, loss of volume on the affected site. A small pneumothorax may not be visualized on a standard inspiratory film, but expiratory film is always beneficial. And the tension pneumothorax is a clinical diagnosis. It is not a radiological diagnosis. Towards tension pneumothorax, there we have a decreased breath sound over the left side in this case. So in this way, we can easily diagnose a tension pneumothorax clinically. We do not need a X-ray to diagnose tension pneumothorax. So this is all about some of the important chest X-rays that might be asked in your exam. So thank you for watching, guys. Please do like, share and subscribe to my channel so that I can make more free videos for all the medical students out there. Thank you, guys.